Hello, I'm Tom Abell, Professor of Medicine and Gastroenterology at UMC, and I want to present some work being done here in Jackson, Mississippi. I'll talk today about two articles in the September 2011 issue of Gastrointestinal Endoscopy on electrical stimulation of the GI tract. Gastric electrical stimulation and gastrointestinal electrical stimulation has been shown to be helpful for patients with the symptoms of gastroparesis, particularly nausea and vomiting. However, who will benefit from electrical stimulation is unknown. Over the past decade, we've developed a novel approach for the placement of electrical stimulation leads, and this was published in 2005 in Gastrointestinal Endoscopy. Today I'll talk about first a double-blind, randomized, placebo-controlled crossover study of gastric electrical stimulation, the so-called Endostim study. This study included 58 consecutive patients with symptoms of gastroparesis randomized either into on or off, or alternatively off and on, after endoscopic placement of electrical stimulation leads in the stomach. There were 72 hours either of on or off stimulation with a 24-hour washout period in between. After the first period, the first session, and the washout period, the devices were crossed over and the patients that were on became off and off became on. Daily symptoms of gastric distress were followed by a patient-reported outcome daily diary, and gastric emptying and electrogastrography were also recorded at baseline after the first 72-hour session and after the second 72-hour session. In addition, a mucosal electrogastrogram was recorded at the time of placement of the electrical stimulator. Electrodes were placed as previously described in 2005 near the body-antral junction and secured with endoscopic clips. The electrode lead was then removed from the endoscope and left out through the mouth. An external electrode was connected to a device and programmed for high-frequency, low-energy stimulation by a remote programmer who was unblinded. However, the nurses, physicians, and of course the patients were masked as to on-off status. Electrogastrography, quality of life, and gastric emptying were recorded, as mentioned before, as well as gastric symptoms. The Figure 1 shows study allocation and design of the patients. Of the 58 patients that were enrolled, 45 completed all 8 days. Again, the main outcome measure was the symptom of vomiting, and secondary outcome measures of EGG, including cutaneous and baseline mucosal, and quality of life were also recorded. As shown in the study allocation slide, of the 58 patients, which were 11 men and 47 women, mean age 46 years, 38 were idiopathic, 13 had diabetes, and 7 were post-surgical. Of the 45 patients who finished, all completed the trial, and 13 patients had device electrodes that became dislodged, 6 in the first group and 7 in the second group, all after the first 3-day session of the study. Data was analyzed using a mixed model approach. Other models were used to further examine the results given the diversity of the patient population. The results are shown in the next slide, and as seen here, a decrease in vomiting was seen in both groups during session 1. But the decrease was much greater in the patient group that had the device on versus off, particularly at day 3 and 4, and the results were statistically significant during the first session. After the crossover period, as shown in the slide, the group that had been on did not return to baseline, and the group that had been off, although it did improve and decrease in vomiting, did not have as great an improvement as the first group in session 1, and thus the results in session 2 were not statistically significant between the two groups. A post-hoc analysis showed that although the patients were randomized, they were physiologically not equal at baseline. In fact, the mucosal EGG values of the first group, the group that was on initially, were more normal than the mucosal electrical activity in those in group 2, the group that was off initially. An addendum describes this and other models as part of further data analysis. In conclusion, for the Endosym study, significant differences in vomiting between the on versus off group were seen in session 1, but were not significant in session 2. These findings could be due to study design differences as well as physiological differences between the groups. So, for future studies, we recommend first, different and probably parallel trial designs. Second, physiologic stratification before randomization. And third, stricter inclusion. For example, those patients with no baseline vomiting need to be accounted for differently in the study. In the same issue of gastrointestinal endoscopy, we have in another article, this on a patient with Roux-Stasis syndrome who had previous gastrectomy for gastric cancer and had recurrent hospitalizations for vomiting and subsequent aspiration. This article, which has a video, documents a significant improvement in this patient using the same technology, that is, high-frequency, low-energy stimulation of the upper gut. Also, in this patient, the measure of mucosal electrical activity was a guide for response for the patient. Taken together, these two articles demonstrate the usefulness of electrical stimulation of the gut for patients with refractory symptoms due to a variety of conditions. It's our hope that the information learned about mucosal electrode placement, physiologic measurements, the type of stimulation, and trial design may be helpful for future patients and future studies with and in a variety of conditions. On behalf of myself and colleagues, we thank you.